Okay, good morning. This is the first lecture on the infant and toddler section of the class. So this is infant nutrition. This guy's name is Robin. He's 4 months old. He's my newest grandson. Okay, so the outline for today, for this lecture, first we'll talk about assessment of infants, just a little bit, about the issue of infant mortality, which I brought up, about health disparities and health equity, failure to thrive, energy and nutrient needs for kids in this age group, and some cautions about lead and some information about infant formula. So there's a lot of things we throw into this topic to kind of get a rounded feel for infant nutrition. Okay, so the first part of the outline was assessment. So this is a slide that shows what an assessment an APGAR score is. Have any of y'all heard of an APGAR score? Somebody say yes or no.
Yes.
Yes, no? You're there. Okay. An APGAR score is a score that's given an infant right at birth by the attendees that are helping with the birth. And what they're doing is they're looking for, as you can see on the left-hand side, those red letters, that's where the word APGAR comes from. And so when an infant is born, they look at the skin color, the heart rate, their reflexes, their muscle tone, and how good their breathing is. So a kid that's doing great, doesn't seem to have any stress, pinks up really fast, and so forth, is strong reactions, as we get a 2, and then sometimes they'll get a lower number. So if they get a 2 in all categories, then the highest APGAR score is a 10. Where this might matter is if you are to work in a pediatric, as a pediatric dietitian, part of the infant's chart would be their APGAR score. So if there are problems at the beginning with irregular respiration and so on, that may have an effect on eating and weight gain and all those things. So that's an APGAR score. It's mainly want you to know what it is. Okay, now this slide talks about, and you're going to be familiar with this too. This slide indicates the types of assessments that occur during the first 0 to 24 months with infants. Now, first is weight for age. Now notice this kid has a diaper on. That's not how it's really done. They usually have a sheet of paper down here and have it teared, and then they strip the baby down and put them on there. So they're usually screaming because they don't like being stripped down. But anyway, so this is how you measure them accurately. So if you hold a baby and stand on a scale at home, it's going to give you a rough estimate of the weight. But if you use these medical scales, then it'll know how much. I mentioned with breastfeeding, lactation consultants often have really high quality scales too, so they can even detect a few ounces different in the baby's weight if it's after breastfeeding. So, but you get weight and then length, and you know that when you hear a baby announcement, right? This weighs this much and is this long, right? So they'll give you length, and length is recumbent, and you can see that down here. And what recumbent length means is that they're laying down. Now, kids are going to lie down for this until they're walking. But typically, they try to have them lie down for the first 24 months because then they use these boards here to stretch them out and then use those boards to get the recumbent length. The reason we care is because these measurements have to be accurate. And I think you talk about some of this in nutritional assessment. So I know some of this is a review, but I just want to make sure you hear it again. Head circumference is another common assessment. What's interesting about head circumference is, there's some correlation with cognition and stuff, and some dietary effects. This is just a fun fact, but diets high in fruits and vegetables have an effect on the increasing head circumference. And then this last one is weight for length. And we're going to talk about this later, because weight for length is how we use to assess how infant body weight, if they're overweight or not. We'll talk about that later. Okay, so here's a growth chart, and I know you've had this experience. So this is weight for length for boys. It's got the World Health Organization signia here, and you can see these lines. And typically, if an infant is born, if you're measuring the birth to 2 years, if they're born and they're on a line like right here, oftentimes they follow these growth lines. So bigger babies may grow along this line, and smaller babies may grow along this line. Not always true, but that's can happen. Some kids can drop, but we'll talk about that. But so this is weight for length. Yeah, weight for length again, and we mentioned this. This is going to be used for assessing overweight later. Now, here's some terms you're going to want to know. Newborn size is classified by weight. So there's the appropriate for gestational age, or AGA, and that's an infant that on the weight chart is between the 10th to the 90th percentile. That's considered appropriate for gestational age. Another category is small for gestational age, and you'll see SGA, you'll see this all throughout the literature on infants. And in their case, their body weight is less than 10th percentile for age. So they're on the bottom of the charts. Then there's large for gestational age. This is a small SGA baby. This is a large for gestational age baby. And in this case, the weight is over the 90th percentile for age. I'm going to talk about both of these groups and their risk factors in just a minute. So just want to get you started on this. Low birth weight is another term you'll see. And low birth weight, the acronym for that is LBW. And notice here that you have absolute weight here in grams and also in pounds. It's important that you know these numbers, okay? So when we'll talk about the importance of birth weight, pretty much throughout this lecture and a little bit in this lecture, and then when we talk about pregnancy, we'll come back full circle and talk about birth weight. For example, when we talk about pregnancy, mom's weight gain during pregnancy and her diet and her health and so forth can affect the size of her infant. She doesn't have full control over that, but she has some. Now, this last category, very low birth weight, often these are kids that are born very prematurely. Their outcomes aren't that good, or they're very small. And the causes of these have to do with something causing the infant not to grow as much in the uterine environment. An example of this is infants whose mothers smoke during pregnancy. Smoking can constrict blood vessels, and because of that constriction, affect nutrient transport, okay, so to the across the placenta to the infant. So smoking is one risk factor for low birth weight babies. Sometimes mom makes a smaller placenta or the attachment isn't that good. There can be some factors that affect growth. And so this is when women go through pregnancy, they have these well-woman exams where they go in and they check the weight, check her weight, see how she's doing, and then estimate. They do measurements on the baby after at specific times, or on the fetus at specific times, to see if the growth is following normal trajectories. So you'll see these all throughout the literature, these terms. Okay, here's a weight for age for boys, just to show you what this looks like. And we talked about, you know, if they're below this has 3rd and 15th, but if they're below the 10th percentile, then they would be small for gestational age, right here. Okay, why do we care about birth weight? All right, look at the list of problems associated with low birth weight babies. These aren't in any particular order. But one risk is mortality, which we're going to talk about. Smaller babies are at increased risk of dying within the first year of life. But then there's also these other health effects, such as allergies, mood disorders, obesity. You know, small babies sometimes have more trouble with obesity than larger babies, or than average for gestational age babies. Metabolic syndrome, irritable bowel, you know, all kinds of things are associated with low birth weight babies. So this is one of the reasons why we try to help women gain the appropriate amount of weight, so that to maximize the chances that the birth weight of the infant will be within a good range. Now, what about the large babies? Okay, so this is a slide that shows the problems associated with large for just LGA babies. Okay, now, so these are large. Remember, they're over the 90th percentile for weight for age. And one problem just has to do with the birth itself. They can be so big that mom has trouble, and the birth situation may end up being a surgical delivery because they get stuck. So shoulder dystocia has to do with the fact that when they're being born, their head can come through, but the shoulders won't both go through. So sometimes there's a requirement to dislocate the shoulder to help the baby get born. And then sometimes because they're large, they use that vacuum delivery where they put like a suction cup on their head and do things to help pull them out because it gets stuck. So that can complicate a normal delivery. This is interesting. They're born, they may be born with low blood sugar. And think about it, how did that happen? Well, if they're in an environment, in the uterine environment, and the calorie input is high, which explains their excess growth. So there are lots of, diabetic moms, a perfect example. If mom's obese or diabetic, then her blood sugar may be higher during the pregnancy. So the baby's got this high blood sugar from the nutrition it's getting from the umbilical cord. Once it's born, however, then the blood sugar starts to drop. Appropriate for gestational age babies that aren't too big or can tolerate not eating very much for the first couple, 3 days and just getting that colostrum and getting started. But infants that are born with, that were large for gestational age, LGA babies, they may respond negatively to not having enough food right at first, and so their blood sugar can drop. And that's something, we mentioned this last time, I believe, but this is something that gets tested. Infant will be tested for blood sugar levels, and if they're low enough, then they'll insist on giving them formula. We talked about this last time. They can give them formula with a spoon or syringe or something like that, but they need calories. So even though we all want to promote best breastfeeding, we do want to make sure that the infant has appropriate blood sugar. So that's one reason they have some medical help.
I have a question real quick.
Yeah.
So I was just wondering if a breastfeeding mother, a pregnant mother, consumes excess calories, does that mean always that the baby is going to be born bigger, or does the body kind of regulate that, or does it just depend on like medical issues of the mother, or what?
Now that's a really good point, because there's a little bit of both. There's some regulation, like a very, it depends on mom's birth, her weight at conception and her rate of weight gain can be correlated with a weight of the baby. Her control of her diabetes, right? If her blood sugar is too high, then that's going to increase the growth inappropriately. But a woman who is obese starting her pregnancy, if she watches her weight during the pregnancy, she's allowed to gain less weight than other people and can actually help keep the baby within normal limits. So and we'll talk about this when we get to pregnancy. So we'll bring back, it's a good question. Okay, so later on, these kids that are born large may be at increased risk for some other of these metabolic conditions too. Okay, so the point is, we don't want them too small, we don't want them too big. Okay, so I mentioned earlier that I was going to talk about infant mortality. Okay, so I just wanted to be clear. I want to check my notes real quick. So infant mortality, here's a definition. This is deaths from birth to age 1 per 1,000 births within 28 days after birth. So in other words, once they're born, they've been around a month, then it's death from that birth until the end of the year. Okay, per 1,000 births. So this is a standard, and we have the infant mortality rate of the United States, different countries, different subgroups within the United States. And so thinking about infant mortality has lots of ramifications. I'm going to talk about that a little bit. Let's look at the primary causes first. Okay, so why do some babies die in the first year? They can be born with serious birth defects, right? Some infants will never survive, and they often find that out during pregnancy. So serious birth defects may produce non-viable children. And then another one, which we've talked about, is low birth weight and preterm births. Okay, so this is why we want to avoid extra small babies to the extent possible, because it increases the risk for death. And you all know this, right? The earlier baby is born before the due date, the more likely it is that there's going to be problems. And then another cause is sudden infant death syndrome, which is an anomaly. Sometimes babies, we've talked about this, but sometimes babies will be seemingly suffocate in their crib. It may be because they have too much exposure to their carbon dioxide that they're breathing out. That's why they don't have bumper pads for cribs anymore. It's back to sleep. You try to, you put them on their back, not on their belly. You put they have little socks now you can put on a baby that's hooked up to their determines their blood rate, their heart rate. And so if and controlled by remote, so you can put the baby to bed with his little sock on, and if something happens to the heart rate, it'll send up an alarm. Okay, so there's some kind of cool materials out there for people to help prevent against this. But these are the primary causes. And I want to read this. I don't like reading to you so much, but this is so poignant. This is, in addition to giving us key information about maternal and infant health, the infant mortality rate is an important marker of the overall health of the society. In 2018, the infant mortality rate in the United States was 5.7 deaths per 1,000 live births. Since you've probably not thought about this before, you may wonder, well, is that bad or good? What's the standard? What do we know about this? Okay, so let's take a look at the next slide. Here is what we know about birth rate and infant mortality. Or this shows us infant mortality. In the next slide, we'll talk about those numbers. So notice here, this is the infant mortality rate. Remember, this is per 1,000 births. So babies that are born early, and here's your weeks gestation. So these are premature babies up to here, or up to here. 37 week is up to 37 is premature. So this is considered premature, and you don't go past this because they'll induce birth if it doesn't happen. Here's the weight in pounds and in grams. And as you can see, the smaller the baby, the higher the infant mortality rate. So note here is not a baby, it's a fetus, right? The larger the fetus, or no, this is a baby, this is after they're born. The larger the baby, you get an increase in survivability and a decrease in infant mortality rate. So somewhere there's a sweet spot in here around 8.5, a little bit over 8.5 pounds, where you have the best possible outcomes. Okay, so again, when we're working with pregnant women, we want to help them, and infants, we want to help them have babies to the extent we can within this range, because that's the healthiest range. Okay, now what about our infant mortality rate? This is slightly old data, and I get graphs from different years. They're always a few years behind because it takes a lot of processed data. This is close enough for our purposes here. The next slide I have a little more current data, but this is roughly, I think I said 5.7, but this is the infant mortality rate in the United States. And so as you can see, when you look at other countries, and I didn't mean to, look at other countries, you can see that some of them have gotten very low on the infant mortality rate. So remember that statement from the CDC that says that this is a marker for the health status of the nation. This is something to think about. Our infant mortality rate is higher than it should be. Now, this is among the hardest things for me to talk about in this class, and also among the most important. Okay, so in the United States, the infant mortality rate is not the same across groups. As you can see here, these are racial ethnic groups. So non-Hispanic Black has the highest infant mortality rate. American Indian, Native Hawaiian or Pacific Islander, Hispanic, non-Hispanic White, and Asian. So our average is about 5.7, which means Black infants are more than twice as likely to experience infant mortality. So the next couple slides I talk about what this is. And so I'm going to just talk a little bit here and then give you the formal definitions. What you're seeing here is something called a health disparity. It's on the next couple of slides. But it has to do with the fact that not everybody experiences the same health outcomes in the nation. Okay, so Black families are more likely to experience infant mortality than, for example, non-Hispanic White and Asian families. Okay, so we could talk about why this is, and it's interesting and it's complicated, and it's something that should be at the top of everyone's mind to address. I found some, I used some of the stuff I've already posted, but I find information for you to take a look at about infant mortality, especially with respect to racial disparities, because this is such a big deal. And I actually want you to look at those materials and be ready to have a discussion at the beginning of our next class about it. So instead of me simply lecturing on what I know about this, I'll talk about it a little bit now, but I would like you to reflect also on the materials that I have there for you. I have some videos that are just very eye-opening about how the world is experienced differently by different people. I'll tell you a couple of examples. People that live in poverty have less access to health care, more health disparities, more incidence of diabetes, things like that. So poverty is a factor, but this isn't just about poverty. Okay. In fact, what you'll find from the readings is that in some cases, the more educated Black women have increased stress and are more likely to have premature infants. So please take a look at the information I have there for you, because it's an important thing for you to think about. Now, when we get to pregnancy, I'll also talk about the differences in maternal mortality in the United States, because that's not an even playing field either. Any comments so far? Are you ready for me to move on? Okay. So I mentioned the term health disparity. So this next section, I'm going to be a little more formal about what a health disparity is and what health equity is. Okay, so this slide is about health disparities. Let's just go through this. If a health outcome is seen to a greater or lesser extent between populations, there is a disparity. For example, the one we've already said is the infant mortality rate is different among different groups in the United States. Those are health disparities. Another example is diabetes. Diabetes is not evenly represented across the population. Different populations have increased risk for diabetes and increased incidence. So why? Here's some reasons that can explain these disparities. Race or ethnicity, and there can be sex, sexual identity, age. These are all variables that may affect people's access to healthcare and survivorship. Disability, money, where they live in the country. All of these things contribute to people's access to good health. Why where you live? Well, some places don't have well woman care that's easy for women to get to. So they can have a pregnancy without having the kind of prenatal care that they need. Perfect example is geographical location. Also income, and also you also know that a good many people in the United States don't have health care. So they're not going to be able to go and find out what their blood sugar is sometimes until they're already in trouble. So that's another example of a disparity. So I'm a firm believer that people should have access to health care, and that when we take care of everyone, everyone does better. When everyone does better, everyone does better. So not only is it ethical, in my view, to take care of people in this way, but it's also, if you don't think about ethics, you just think about money, it's cheaper if people are healthy too. Okay, so if we provide health care and help people avoid chronic diseases and so forth, the nation spends less money on health care. So there's a financial incentive as well as an ethical incentive. So the government puts out healthy people goals. Okay, you've probably heard this in some of your classes. There's Healthy People 2000. That was the goals set before 2000 happened. Then there was a 2010 goal, and then the 2020 goal. So these goals have helped set policy. So where does our money go in the United States to help individual groups improve their health outcomes? Well, in this case, some money is allocated to reducing health disparities among Americans. And then 10 years later, it was to eliminate, not just reduce health disparities, which we're not there yet at all. And then another, 2020, the goal was expanded to achieve health equity, which I'm going to talk about on the next slide. Eliminate disparities and improve the health of all groups. So the idea here is to make everyone have access and the same conditions, not have health disparities. Okay, so at the bottom of the slide, I asked them, what is health equity? And I need to slow down a little bit and make sure you can process this with me. So I'm going to talk a little slow on this next slide. And you are welcome, instead of asking Kristen in a chat box, what did she say? You're invited to say, what did you say to me? Because if you didn't hear it, if I'm going too fast, it would help me meet the needs of you guys better. So health equity, it's the attainment of the highest level of health for all. Requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical injustices, and the elimination of health and healthcare disparities. So this is, again, when everyone does better, everyone does better. So here's an image from the Robert Wood Johnson Foundation, and it shows a difference between equality and equity. So equality, let's say you were giving everybody a bike and you want to give everybody the exact, you want to give equality. So you give everybody a bike. As you can see here, people are different. Okay, so this bike is not particularly useful for this person, or this person, or this person. Okay, so just being equal across the board is not always how you achieve equity. Equity is when you consider what people's needs are and provide specific measures to help them all have the same ability to have good health outcomes. So I thought of a couple examples about this. One is school meals. Okay, so y'all know we have a national school meal program, and we've fought over the years to improve the health. I've done a lot of research with it, but we've fought to improve the healthfulness of foods offered. Remember, Michelle Obama sponsored the program that helped improve the school meals and so on. And since and more recently, some of those improvements have been rolled back. But let's say that we don't value healthy meals for kids at school. Let's say we give up. It's going to be pizza from now on. Okay. It depends. So here's everybody's pizza. Okay. That bike is a pizza. Some people are going to be hurt more by that pizza every day than others, right? You give everybody 2 slices of pizza, okay? But some people who don't have healthy food at home and are getting pizza at home and unhealthful food, this can really compound their health issues related to their diet. Also, if they're not getting healthy foods, they probably aren't getting enough vitamins and minerals and fiber. Okay, so for kids that are in more elite, I guess, or wealthy households, pizza is not going to change your life probably that much. And it may decrease their health. Sure, pizza every day is going to do that, but not to the extent that someone that's already suffering from overweight and has poor access to food. Does that make sense? Okay, so one size fits all isn't always the same. Okay, so in order to improve the outcomes for people, we need to meet them where they are. Public health needs to take a look at what do you need, and different communities need different things. Some of the literature I read, there were focus groups from African-American females who had experienced infant mortality. And instead of having them fill out a survey or that type of thing, what they did is they ran a bunch of focus groups with them and said, what do you think? How do you feel about this? What was your experience? In other words, trying to probe at the underpinning of that health inequity, the fact that there wasn't health equity. And some of the comments were, when I go to see a healthcare professional, they don't always listen to me. I don't feel respected. I feel like I have a different scenario. I have a different experience going to the hospital or going to seek healthcare than other people do. So that's an example of potential causes. Maybe people aren't as likely to get engaged in healthcare, potential causes for lack of health equity. so that we can move forward. So I wanted to get the idea across here that it's not an even playing field for everyone, and not all the same people need the same resources. Does that make sense?
Yes, it does.
Yes. Thank you. Somebody spoke. Thank you so much. I appreciate it. Okay, so I'm going to go off this topic now. You're going to read, make note, you're going to read about it and look at the videos that I posted for you. We're going to start next class on this topic again. So to have some reflection. Okay, so I'm going to change topics now. And the next topic is something called failure to thrive. Now, if I were in a classroom, I would ask you how many of you have experienced failure to thrive. Not experienced it yourself, but have familiar with this term. And so I assume some of you probably have heard it before and some of you probably haven't. The acronym is FTT, and that's very commonly known. So how's this diagnosed and what is it? Okay, failure to thrive means basically not growing well enough, not growing according to potential. And this condition is diagnosed in young children. And here's what is used for diagnosis. One is if their weight for length is less than 80% of what it should be, the median value. These other ones are easier to understand. If their weight for age drops down 2 major percentiles. So remember those growth charts. Instead of following a line, if a kid is on a line and then drops down to 2 major percentile groups. Okay, so I'll show you a picture of that in just a second. So they stop gaining. They may have been gaining and then they stop gaining. And then another one is weight persistently below the 3rd or 5th percentiles. These kids may have failure to thrive. Now, one thing you need to know is some people have to be smaller than others. That's the nature of a bell curve, right? So there's going to be people that are smaller and there's going to be infants that are larger. Sometimes an infant is this small because the family's small. They could just be, the people may be short of stature, so the babies are going to be smaller. I had a family member like that. Her mother's Chinese and her father is half, I guess he's Hispanic, and it's my brother's son. And their kid has always been at the 1st percentile. But she's fine, she's brilliant, she's just little. Her mom's Chinese and she's little too. So you want to pay attention to size before you make before you decide, oh, if a child's at a 3rd percentile, then they must have failure to thrive. You need to ask a couple more questions, and see what's going on. Some kids that don't grow can have a reduced head circumference, and that's really serious too. It's affected their brain volume. Okay, so here's the growth chart I was going to show you. And here we go. So if you see here, this is a plotted kid with failure to thrive. You can see right here that the started out here on this higher growth chart and then slowly crossed over several of them. So that's an example of failure to thrive. And sometimes they can say, what happened? Like, what happened to the kid? Maybe they put in a foster home or something serious could happen, and you can see a cause of it. There can be nutritional causes and social causes. So what are the fundamental causes? Well, basically, if a kid's not growing, then they're not getting enough calories to support their growth. It's kind of simple, right? Because children should always grow. If a child stops growing, or starts going backwards and losing weight, especially a young child, I'll talk about body weight later, then there's a problem. So for some reason, the intake is not meeting their needs for growth. One, it could be they're just not eating enough. Some infants are born with a weak suck and they're not very good at nursing. Some kids aren't as hungry naturally. Some have trouble with motor control. Different kinds of things like muscular dystrophy can affect ability to eat. Down syndrome infants have trouble with controlling their mouth at first. So there can be just not taking in enough, picky eaters, all kinds of things. Or there could be a malabsorption problem. And this requires medical diagnosis, but maybe a kid's got celiac disease. All right, so celiac disease is an example where they're just not absorbing their nutrients. And they have other symptoms too, and hopefully be able to figure it out. Then the other option is they're burning more calories than they would normally burn. So maybe they're eating enough or not. But an example of this is chronic lung disease. When infants have chronic lung disease, they need more calories to keep going. So these are some fundamental causes: not getting enough calories, not absorbing enough calories, and burning too many calories to meet the needs for growth. Okay, so this slide talks about issues surrounding failure to thrive. Okay, so diet, there can be absolutely dietary problems. This is in your wheelhouse, so we're talking about this, but it's good for you to know other things about failure to thrive besides just diet. But let's take a look. So breastfeeding difficulties. Remember we talked about last time, it could be mom may not produce enough milk, or there may be problems with the tongue tie, things like that that are interfering with the transfer of milk. Improper formula mixing. In the event that a family is poor and is not using, for example, WIC, the WIC program in the United States is awesome for providing formula for families that can't afford it. But if they're not getting adequate amounts of formula, they may stretch it out. So instead of making it according to how you're supposed to in the proper recipe, they may just dilute it out with more water. Okay, and that's devastating because the infant's filling up on water and not getting those nutrients. And then some kids have trouble with that control, and they just don't eat well when they first get started, and they may have a period of time where they don't grow well. Excessive juice intake can just displace other foods. Some families start this habit where kids love you when you give them sugar, right? And they start the habit of juice, and then the kids are pretty much addicted to juice, and it's an important thing for them to have. So we'll talk about juice later, but my recommendations, echoed by all the major health organizations, is don't give little kids juice. We'll be more specific about that later. And then they may avoid high calorie foods. Some kids are just picky eaters, and we'll talk about that this semester too. It's a little harder to get at why they're picky eaters and what to do about that, but there are definitely things that you can do. Now, what about the family? The family, as I mentioned earlier, the world is not an even playing field for anybody. And so some families know a lot more about nutrition. They may already be interested in nutrition themselves. Parents may be good role models. They may be lucky. They may have enough money. They may have, they may not be at work all the time. They may have some time more time to devote and more knowledge. Okay, some families are barely making ends meet. One of the reasons is because our minimum wage in the United States is not enough to support survivorship in many cities. And so in this case, not enough money, poverty can be a problem, mental health can be a problem. And so in the event of family chaos, the children may be getting neglected, and that can be a cause. So you notice on the left, there's dietary causes. And then on the right over here under family, these are more social issues. Now, knowledge of nutrition is a great niche for us, right? So people that are interested, I think people become more interested in health in their lifetime when they're pregnant and looking at taking after a new person than any other time. So it's a great opportunity to intervene with families and provide information. Okay, and the last couple of issues are, it can be genetics, as we talked about, Down syndrome, there's a lot of conditions, and then health issues, an example of celiac disease. So there can be a variety of factors. It doesn't have to be just one, but these are the things you want to keep in mind when you're trying to consider where is failure to thrive coming from. Okay, so what do we do about assessing? In terms of feeding, making an observation with the family is ideal. There's some studies where researchers go in and hang out during dinner and watch interactions. You have to do that a little bit so you don't interfere with their normal patterns, but observing families feeding is very helpful. So you can observe bottle feeding and see if they're getting enough, make sure the bottle works, make sure the hole's big enough. Spoon feeding, is the kid able to open their mouth and put it around a spoon? Can the child feed itself? Well, we'll talk all about these things later. And then a nutritionist can also do a 24-hour recall or a series of 3 24-hour recalls and really do a hardcore assessment of what their nutrient intake is like. So this is a professional venue. If I were to not be in academia and wanted to make the most good in people's lives, I think this would be a very interesting place to address health in the United States. Because if we get the kids off to a good start, they're a lot more likely not to get sick later, okay? So then what do? Well, there's gonna be clinical interventions here too. This is not something you handle alone. If you're a dietitian, nutritionist, and you find that a child has failure to thrive, it is your duty to make sure that the social services are aware of this. And now in a hospital environment, they're going to be called in because there's many redundancies. But let's say in private practice, you encounter a child that's not growing. This is important. It could be a nutritional issue, or it could be something else, and the ramifications can be serious. So what kind of lab tests should be done? Well, there's genetic testing, and then there's these routine tests that really may provide rich information. One is checking for anemia or iron deficiency. And we talk about this all through the semester, but iron deficiency is dead serious. It interferes with growth and cognitive function. And if iron deficiency is one of the problems, that needs to be found out and corrected. Another problem, which I'll talk about today as well, is lead poisoning. In some environments, kids are exposed to lead. Lead interferes with appetite, neurotransmitter production, and can permanently affect IQ and strength. And then sometimes kids have these urinary tract infections just out of the blue. And I think this is so interesting because they can't tell you. So they just act funny and they cry and they can't, they don't even know what's going on. Kids with urinary tract infections can feel pretty bad. Sometimes when a child has inconsolable crying, they need to go to a pediatric ER to see what's going on, and they can diagnose things like this. Okay, so these are examples of what clinical dietitians would be involved, and private practice dietitians might be involved with. So the last slide on failure to thrive has to do with management and prognosis. So how do we help? Well, this is right in our wheelhouse, right? Nutrition education, feeding interventions. So parents may need some help on figuring out how to feed their kids. There may be things you can't do, and we'll talk about this. In some cases, it seems very easy to be able to feed an infant right, but in some cases, it's hard for people. The infant may not like the taste of food, and they may reject it, or parents may try to force them to eat it. And so there's there's a whole genre of how to do this that has to do with responsive parenting, where parents sit down, look at the child, have pleasant interactions, offer them food, and allow the infant to choose. Does it want it? How much? And so this is a respectful division of labor. We'll talk about this too. That would be an appropriate feeding practice, but sometimes people are confused about the best way to feed their kids. They may yell at kids and say, you have to eat all this. I don't know how many, probably half of you have had somebody make you eat your food before. And it doesn't work, right? It's not like you learn to like it after that. So monitoring growth would be a big part of it. So plotting. And this is one of the issues with healthcare too. If people aren't getting regular healthcare, who's minding the trajectory of the children? Okay, what's their growth like? So it's another potential for health disparity. So what happens to these guys? Well, with interventions, they usually start gaining more weight. They grow, they learn to eat. Some stay anxious and some need more help. Long-term though, the reason we don't want to let this just go is that cognition, brain growth requires adequate calories and protein. Cognition requires adequate vitamin and mineral status, in particular iron. So infants that are starving or having low intakes of necessary nutrients may have long-term effects from being a failure to thrive kid. Okay, any questions about Failure to Thrive? Have any come in on the chat, Kristen?
Nope, there's been no questions.
Nothing?
Nope.
Anybody? Are y'all still there?
Yes.
Still here.
Thank you. Okay. Energy and nutrient needs. Think about this. Well, I don't know how much you thought about this, but we have RDAs for nutrients, right? So we know about how much vitamin C you should take if you're an adult female, for example. Right? I mean, we have an RDA for that. And we've done that from experiments where people over the years have taken groups of individuals, made them deficient in vitamin C, and added enough back to get them to where they produce all the things vitamin C needs to do, and you've got maximum functionality of vitamin C. And then continue to feed them until it's too much, and so you figure out where the sweet spot is. How much do you need to have normal physiology? Okay, so we can do those experiments with adults. In fact, I've been involved with one in manganese when I was in grad school. So we can do that with adults, but you can't do it with an infant. You can't take a group of infants and make half of them deficient in vitamin C and see what happens. Can you? Okay, so because you can't do that, what can you do? Well, what we use is the standard of the average intake of breastfed babies. So we know about how much breast milk babies consume over a period of time. So then breast milk has been analyzed, and the amount of food or about nutrients in the breast milk is what determines their nutrient needs. It's imperfect, it's an estimate, but this is all we can go by. So as I do with all of these, I'm only going to point out a couple of nutrients. So this slide shows infants 0 to 6 months, and the next one shows kids 6 to 12 months, or more like 7 to 12 months. So let me talk a little bit about these numbers. The energy requirements are expressed in calories per kilogram. What that means is the infant's weight determines how many calories they need. So smaller infants are going to need fewer, larger infants are going to need more. Why would you do this? Well, these numbers are typically used in a clinical setting. One of the more interesting aspects of dietetics is working with pediatric nutrition. If there's infants in the hospital that are having trouble growing, having trouble getting enough calories, the dietitian plays as big a role as the other healthcare providers because it's a puzzle. And it's interesting to figure out. So the dietitian's going to go in and be involved in how much nourishment the infants get. And if they're getting bottles in hospitals, they have sort of like little graduated cylinders. They can tell how much they consume. So they write down how much formula was consumed or how much breast milk was consumed. And then they can figure out the calories from that over a 24-hour period and then decide how close they're getting to their energy requirements. So that these are, and there's all kinds of things now that you can have a calculator that figures all this out. But this is when I was getting my RD, we did everything by hand. Okay, so protein, this is a very high amount of protein. Do you remember how much protein adults need in grams per kilogram?
Is it
Somebody holler.
half of that, like is it maybe 1.2?
Somebody in the comments said 0.8.
Yeah, I can't hear. It's 0.8 grams per kilogram. So see, for body weight, they need a lot more protein. Does this mean they need to eat a whole lot of protein? No, they're little. Okay, so an 8-pound baby needs just a little bit of protein, right? So an adult weighs 150 pounds. So there's a real difference. So just while they're growing, this is the energy, this is the protein requirements. I'm going to go to the next slide. This is for 6 to 12 months, and you can see that the energy requirements and protein goes down per body weight.
I have a question real quick.
Yeah.
Which of these nutrient values are we going to need to have memorized for our exams?
So what numbers do you have to memorize?
For our exams for this class.
You would need to know these figures. I don't throw in figures. I leave many figures out of slides so that I just try to put in what's critical here. These are numbers I really want you to know. It's a good question. So And let's talk about, and notice I'm not talking about every nutrient, I'm just pulling on the big ones here. For fat, about 30 grams per day. And notice that there's a recommendation for omega-3 fats. Okay, so we need to have these little guys getting in omega-3 fats. It would be in formula or in breast milk. Water is based on how many calories they're using. If they're exclusively bread fed or formula fed, they don't need any extra water. Vitamin D, we've already talked about. Then this is something I want to draw attention to. Okay, so you see this number, 0.27 milligrams per day, right? Okay, look at the next slide. This is up until 6 months, okay? Look at the next slide. What happened to the iron requirement?
Went up.
Did it go way up?
Yeah.
Okay, it goes way up. So 0 to 6 months, the AI for iron is really low. Breast milk doesn't have much. Okay, so, and they're not at risk for deficiency quite yet. They may be getting there, but when the kids get older is when iron deficiency really kicks in. And here's one of the reasons: when they get bigger, they need a lot more iron. So your question about what do we have to know, you absolutely want to know the differences in iron requirements from the smaller babies to the larger ones. And the reason this happens is because they're at risk for deficiency. And so diet, starting at 6 months, diet plays a very important role. So the whole concept of a lot of your papers you're working on in this class is that these are critical periods of development and growth during these early years. Okay. So those are the things I wanted to highlight. And then I pull a couple of these out and talk about them. So iron. As I told you, throughout the semester, I'm going to talk about iron all the time because it's a major problem. So notice how much iron is in human milk compared to formula. Y'all see a difference in those numbers? Which one has more, human milk or formula?
Human milk.
Formula does.
Yeah, because look at how much is in there. 0.5 milligrams per liter. Remember, a liter is about a quart, whereas formula has 12. So we add a lot of iron to infant formula. You know why? It's right there. It's not very bioavailable. What that means is they add a lot of iron to formula and a lot of it doesn't get absorbed. So they have to add this much in order to meet nutrient needs. Breast milk has a lot less iron, but it's much more available for the infant. Do you remember the protein that carries iron in human milk?
Lactoferrin.
Perfect. Yes, lactoferrin. So in human milk, iron is in the form of lactoferrin, and that helps with bioavailability. Okay, so let's look at the bigger kids. Baby food meats, fish, fortified cereals, beans and lentils, eggs and dried fruit. These are all good sources of iron. Your book has a mistake in it with respect to first foods. We're going to talk about first foods in the next recommendation, like what should you have first? Does it matter? What, you know, how do you go about it? So we'll get to that. But your book says to start out with fortified rice cereal. And so if you've read that, make a note that that's not the case anymore. I'll explain that when we talk about cereals in the next lecture. But the other baby, and when I'm talking about cereals here, I'm talking about baby food cereals, not, you know, total cereal or something like that. These are cereals that are marketed for infants. And what they do is they make sure that they have a good amount of iron and a good amount of zinc in them. So the cereals are a good first line of defense to help protect them from developing iron deficiency anemia. But the baby food meats and fish, you know, the bioavailability is higher, and if the family does want to consume those items, then that would be appropriate. So one other thing to watch out for, and I'll bring this up again in the next lecture as well, is milk. Milk is interesting. The dairy lobby has had a big effect on what we think about milk. You ask any kid, why do you drink milk? Oh, it's got calcium in it, right? It's good for my bones. They've done a very good job of making sure everybody thinks that. And certainly there's calcium in milk and it can be fine, but It is not a replacement for breast milk or formula and should never be replaced under the age of 1. In fact, there's not a big requirement for milk later. We'll talk about this too. But under age 1, milk can cause anemia. Whatever you do to highlight your notes, highlight them right here. Okay, the anemia is linked to early introduction of cow's milk. And the reason is it's not nutritious, it's low in iron. First point. The second point is milk can cause bleeding of the gastrointestinal tract of an infant. And that can accumulate to where they've got iron loss. And then the third point is that regular cow milk can, if the kids are drinking this, they're not getting formula or human milk in the same volume, and those are the high nutrient dense foods. Cow milk is not made for humans, it's made for baby cows. Baby cows aren't growing brains that much. What they're doing is getting out running around, right? So humans don't do a lot of that. So the formula is not right of cow milk for infants, but this is a big caution. Iron deficiency anemia, a lot of families think, oh, I'm doing milk, I'm doing the right thing, and they can get these kids started and it's cheaper. The formula costs too much money. You're supposed to use it for the first year of life if you're using formula. The older kids are drinking milk, you can just get people maybe tempted to cut back on the formula and just start offering milk. It doesn't work. So what do you look for in iron deficiency anemia? You look for symptoms like irritability, anorexia, meaning done for weight gain, don't like to eat. And you know, some babies are just like this anyway. So there's that, but this can be an indicator of iron deficiency anemia developing.
Dr. Krischel,
Yeah.
do you mind going back to the slide with all the nutrient needs for the 6 to 12 month? Yeah, thank you for just a second. Okay, thank you so much.
Absolutely. Please stop me anytime. Are you guys getting access to these PowerPoints? Can y'all download them?
Yes.
Yes.
Okay, I just want to make sure there's not a problem with that. Stop me anytime. I would much rather you stop me than just tolerate it while I keep rambling on. So it's very helpful. Thank you. Okay, so got it, iron, milk bad. Okay, here's another issue I wanted to pull out. This has to do with fluoride. You guys probably know that our municipal water supplies are fluoridated, right? Why do we have fluoride in water supply? We have fluoride because it helps prevent dental caries. It's a public health initiative. So fluoride has been added to water. People that have well water don't use municipal sources. So they may have a different amount of fluoride in their water. This is something that people need education about. I don't care that you know the DRIs. I will not ask you the DRIs here. I put them here because I like you to have a good set of notes. In this particular case, I won't ask you how much fluoride you need, infant needs. What I will ask you is what are the problems with excess intake? Now, for the first part, you look here at one thing is called fluorosis, and that's what that image is. You can see those teeth have really dense white areas on them. When infants get too much fluoride, between 0 and 8 years pretty much, then that'll cause white spots on their teeth. Sometimes it's not very noticeable and sometimes it's really disfiguring. So it just depends. So that's one problem. But bigger deal than that is that fluoride, excess fluoride, is a neurotoxin. And for this lecture, you can see I have a citation at the bottom. I went and took a look at what's the current state of knowledge about fluoride and infants. And the consensus is from studies all over the globe that we don't want to have excess fluoride consumption, and that there's actually been links to cognitive problems in a dose-dependent fashion. So the more fluoride, the bigger the problem. So where do kids get fluoride? They get it from water, black tea, which you might not think you would give infant black tea, but people do that sometimes, and toothpaste. So fluoridated water, it depends on your water source. If people are getting well water, they need to check their levels. If it's high in fluoride, then they need to buy bottled water or distilled. You can get distilled water that doesn't have fluoride in it and use that periodically. And also, you don't give them toothpaste with fluoride until they're big enough to spit. Because when they're younger, whatever you put on a toothbrush, they pretty much gnaw on it and eat it, right? So you can't be giving them fluoride then. So I just want you to understand that this is an issue, and that the take-home message is that you need to have, people need to check their water level for fluoride.
So does this ever happen to humans? Like it becoming toxic to us? Like if we drink too much water?
No, I think it's more of a developmental issue. It has to do with neurotransmitter synthesis. I think it's a developmental issue. So it's during the early years. The early years when people are growing and developing cells and so forth, those are called critical periods of development where things need to be just right. And when you get older, I don't know that fluoride's such a problem. I may be wrong because I basically just looked this up for kids, but it doesn't come across my desk as an issue. I do a lot of general reading about nutrition health just to make sure I don't miss things, and I'm not very concerned unless someone has, I guess, very high levels of fluoride, and then they might want to moderate that just for the family as well.
Sounds good. Yeah, I've heard a lot of bad things about fluoride, and I could see why, like it's good for our teeth, but I could see why it could have detrimental effects on the body. But I don't know.
Well, it certainly does for kids. I mentioned last time how, one or two papers doesn't always tell us something, but when you read a lot of different papers and they all come to the same conclusion, not every paper has come to this conclusion, but the vast majority of them have. So what that means is there's pretty good evidence that fluoride is a problem as a neurotoxin for growing children. Okay? In terms of evidence for adults, I didn't prepare that for this class because we're not talking about adults here, but I want you to know this isn't a conspiracy theory. Okay, we have to worry about this, right? Because these urban legends happen all the time, and it's hard to tell the difference between, is this just what people are saying, or is this really true? So that's my job when I'm putting your lecture together, to feel confident that I'm giving you current state of knowledge. And so that's what I do. So when I prepare these, I look up all, anything that I'm concerned may have changed and so forth. But I didn't look it up for adults. But my understanding is this really applies to kids more. It'd be an easy PubMed search though. Okay. Is lead a nutrient?
No.
Yes, no.
Remember what a nutrient is? I know you do, right? It must be consumed in diet because you don't have enough, right? And so do we need lead?
No.
No, we don't need lead. Lead is not a nutrient. No. Okay. Lead is a contaminant that's terrible. See that picture of paint chips up at the right-hand side of this? Lead-based paint, one little paint chip like that can give a kid a toxic dose of lead. So, and so the next picture is a guy wearing a hazmat suit, sanding down the paint, lead-based paint that was on an old house. Old houses can have lead-based paint on the outside or on the inside. And lead is terrible for pregnancy and for adults. This one gets people all up and down the age range, but in particular during pregnancy and infancy, lead is serious. I'll tell you how serious it is in the next couple slides. But so to clean it up, the hazmat suit is required because if he was just sanding this paint off and breathing it, he'd be getting toxic amounts of lead. Adults that get toxic amount of leads can end up dying, but they can also lose a lot of their body weight and just really get sick, and it's hard for them to get back out of it. So where do you get lead? House painted before 1978. House is built before 1950 because of lead pipes. Water pipes. I don't know how much you remember of the story in Flint, Michigan, where individuals decided to provide water from another source, and they used old pipes, and so they poisoned the children in the community with lead. This is an example of a horrific health disparity. Also, you got to be careful about older painted cribs. You go to one of those garage sales or antique shops. Those may look cool, but there's a couple things wrong with them. The paint can have lead on them, and also the slats can be too far apart, and babies can like get their heads stuck in there. So those aren't cute anymore. And then some toys, some of the plastic toys may still have some lead. And then leaded gasoline. So my generation grew up with leaded gasoline. So when you wonder why we don't remember anything, this is part of the problem, okay? Because we had direct contact with lead. So here's a little kid chewing on a windowsill with flaking lead, okay?
Ma'am,
Yeah.
why would they use lead? I mean, why was it so like used in everyday common things? Like why did they choose lead?
The paints were prettier. So it made really bright white paints. And so it was just a quality issue. So, oh, this looks really good. Oh, yeah, I left out in lead pipes just because that's what we had for solder. And now we have other types. We use PVC and different other things. So it was for that. One other source, doesn't really affect infants, but I should bring it up, is ammo. If you happen to be a Second Amendment gun-toting American, be careful about the lead and from some of the ammunition, and also from fishing. If you fish a lot and you handle lots of lead with your bare hand, that can actually provide an exposure as well. So it just didn't fit for kids here, so I didn't really talk about it. But anyway, we thought it was pretty. I just didn't know any better. Why is it so bad? Cognitive impairment, permanent loss of IQ, lack of ability to think. Teachers may notice this in school. But this behavior also kind of parallels iron deficiency anemia too. Depends on the kids, but it's hard. Something's wrong when kids are acting out. Prenatal exposure. Let's say mom moves into this, or she gets pregnant while living in a lead-based house and decides to do some painting work on the house. She can have a serious effect on her pregnancy. Long-term effects, depression, anxiety. How much? Now this is the crucial piece. For years, the FDA said, well, as long as it's below 10 micrograms per deciliter in the blood, it's okay. Now they said there's no safe level. That's why I have that in all caps. No safe levels of lead. So any amount of lead exposure can have effect on IQ. Now, what do? Let's say you have a kid that's got this trouble. They take them in. They find out they've got high levels of lead in their blood. They can do something called chelation therapy, where they pull the blood out and run it through a column, and it'll pull the lead out and lower, and then put the blood back in. So it lowers the lead content of the blood, but it doesn't improve the IQ issues. It can lower the toxic amounts, but this is persistent. And this is what was so bad with Flint, Michigan, is that a whole large group of children had lead water with large amounts of lead in it for a period of time. The community was just devastated by this. So what do you want to do? Don't do that, right? In a perfect world where there was health equity, that wouldn't have happened. Prevention, don't buy, now when you buy a house, they actually have a lead notification. But if you live in an apartment somewhere, low income housing, figure that there may be lead. And so if kids are crawling around on the floor and there's lead from the paint, then that could be a problem as well. So, and then good nutrition. I don't know if you remember your chemistry, but lead is a +2 or a divalent cation. So are iron and calcium. And if nutritional status is good of iron and calcium, that's protective. So a healthy situation is a kid that doesn't get exposed to lead, eats plenty of iron and calcium. A bad scenario is a child perhaps living in a old housing with exposure to lead from either the water pipes or the paint. and then a poor diet. Any comments about lead? Okay, so